and
First read,
ask the
okay.
maximum questions.
No, no. I don't ask question. I always learn. I'm sitting there to learn.
Hmm.
Hmm.
It's an
चलो so
honor to speak in front of you, right?
okay नहीं नहीं काका it is my honor to attend your class. So अभी तो 20 मिनट है.
Ah, bilkul, we have 20 minutes in hand. But I logged in earlier just to confirm that there are no technical glitches should not be there.
Yes,
The
yes,
technology
yes,
is
yes,
what do you call?
yes.
Technology sometimes glitches ditches you like anything.
Yeah. You can. So that the technology is not a very reliable friend.
Yeah, I mean, if it is good, it's very, very good. If it is bad, it's very, very bad.
Yes. I fully agree with you. चलिए.
Dr. Manish is here.
You are in your OPD right now or at home?
No, I'm in the hospital still, sir. I can't
अच्छा
leave
अच्छा.
the hospital, and 3 to 4 is a very odd time. I would be driving anyway, so either I had to stay in the hospital, overstay and take the class, or I leave early, reach my place, and then take the class. So
आज का अभी का टॉपिक क्या है?
my topic is diabetes in young.
यंग पीपल. ओके. तो मेनली टाइप 1 पे ही बोलेंगी आप.
No. I'm not talking on type 1, sir.
चलो. टाइप 1 MODY blah 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 everything will be included.
Exactly.
चलो I'll join again at 2 o'clock.
Sure,
Oh,
sir.
3 o'clock. 3 o'clock. You carry on. Okay.
Good afternoon, everyone. So, when do we begin?
Good afternoon, ma'am. You can start.
I can start. Where is
Yeah.
like somebody is there to introduce, or any seniors are here?
No, ma'am. No, ma'am.
Dr. Puneet was supposed to join. I'll ask Dr. Puneet Saxena if he's joining. Sir is here. Sir, good afternoon.
Good afternoon, Dr. Meenal. I
आपका
think
ये
people will be joining in 5-10 minutes. So
Yes, we are waiting for you. आप आ जाओ फिर शुरू करते हैं.
yes. So let me introduce you. So good afternoon, everybody, and welcome all to the another class of this ICP short certificate course under the auspices of Indian College of Physicians. And we have held up till now 5 classes, and all of them have been interesting and have been joined by so many people. So continuing with that, we now have an eminent speaker with us from Jaipur. She is Dr. Meenal Mohit, who is the head of endocrinology at Manipal Hospital, Jaipur. And she is many of you must be knowing her because she speaks on so many forums and is an active member of so many associations and is always active in academic activities. So she'll be taking up the diabetes in young, which is a very pertinent topic because most of the confusion regarding the diagnosis and management, or you can say even the prognosis, is very difficult in this subset of population, the younger population, maybe say some 15 to 30, 35 years of age. So there you are in dilemma that what kind of diabetes you are dealing with. So we have kept a special session on that, and looking to the numbers which are increasing in this age group, it becomes altogether more important to have a discussion on this. So I will ask Dr. Meenal to kindly proceed, and people have joined, so many people, and many more will be joining in the short period of time. So over to you, Dr. Meenal.
Thank you, sir. Thank you so much for your kind words, and thank you for inviting me on this platform, giving me this opportunity to talk. And as you rightly said, the topic diabetes in young is a very relevant topic because every other day we are finding that the age is decreasing, the of presentation is decreasing, and our dilemma to diagnose and make the right choice of treatment is definitely getting more confusing. So, if you allow me, I'll share my slides.
Please go ahead.
So as you can see, we are beginning with diabetes in young. The very first slide, as we can see, talks about the confusion that we are facing nowadays. Still, of course, the largest number is type 1. The largest share still remains with type 1. But you will also find that now a large number of young population actually presents to us with type 2 diabetes. Here again, we are having a confusion whether it is MODY or a monogenic variant of diabetes, or is it truly a type 2 diabetes? So we really need to differentiate whether it is MODY or whether it is type 2, or are we still dealing with type 1, or we have certain other missing loops somewhere. What are the exact diagnosis we still need to find out? So let's see. The presentation can be anything. It can be varied, beginning from any gentleman presenting to us from a rural area or an elite corporate world. It can be a lean, thin individual presenting to you for the very first time. It can be a night shift worker or any employee working in any of the factories, or it can be an overweight young adult. The presentations are quite varied and they all share one common thing underlying, and that is type of diabetes that we need to make out by the end of this session. Presentation is hyperglycemia. Similarly, gender has no bias. It can be a woman from the rural background. It can be pregnancy diabetes. It can be, again, another night shift worker. It can be a young girl with PCOS, where we might find out early onset hyperglycemia, or it can be even one of us. So the presentations may vary, but one thing remains common. Most of them I have taken, these are all hypothetical cases just to make the presentation interesting. Most of them are presenting around 25, say all are young diabetic patients. Most of them have high fasting, high postprandial. HbA1c is again in the range of 9.5. Now, this particular gentleman has no past medical history. BMI is giving away the diagnosis. He is sedentary in the habits, and as you can see, the lifestyle, the food you can see. Both parents have diabetes, a strong family history of diabetes. So as you can understand, we are leading probably to a case of young onset type 2 diabetes. If you look at this corporate gentleman, again, 25 years, same figures, same sugars, same HbA1c, no past medical history, but he is a fit gentleman with a perfectly balanced BMI, that is 22 kilograms per meter square. Another software engineer. Now focus here, the 3 generations. Father had diabetes, grandfather have diabetes, and they were also diagnosed around the same age. So 3 generations involved, presentation around 25, not obese. What are we talking around? We are talking around MODY. Okay, what about this gentleman? Another similar picture, 25, same figures, same HbA1c. He's a lean, thin individual, underweight individual, no family history for diabetes. Where do you think we are talking? We are leading this case to? We are making a pointer towards either LADA or maybe type 1. Now this girl presenting with history of PCOS, same picture, same age, same figures, everything same. But again, a family history positive and a history of PCOS. Though she's not obese, but she is still overweight. Again, probably an early onset type 2 diabetes. That is what we are talking. Lady with a history of GDM. Again, a pointer of early onset type 2 DM. Any women with history of GDM, we have a very strong predisposition that this woman is likely to develop type 2 diabetes if she does not take care. Then here comes the role of chronomedicine we are talking. Change in the daytime working, daytime sleeping pattern, and the late night working hours of the night shift workers, change in melatonin, change in our biological clocks, probably again a very strong predisposition to early onset type 2 diabetes. So why diabetes in young? We have many reasons now. I think by far we have discussed. Even type 1 has shown an increasing preponderance, increasing prevalence, and increasing incidence, especially after corona. But besides type 1, our changing fat diet habits, our changing sedentary habits, increased sedentary habits and decreased exercise habits, our increasing body weights, increasing BMI, increasing waist height ratio or increasing waist hip ratio, Then, of course, we have the genetic mutations, underlying genes. It can be monogenic or it can be polygenic. Another important thing, these young population may not come to you directly with very high sugars or with ketosis. The sugars might even be normal at presentation. And you will find there are pointers of insulin resistance, like there is hyperinsulinemia, there is acanthosis, the population is overweight or obese. You might find hyperglycemia only on oral glucose tolerance test. So there can be IFG, that is impaired fasting, or there can be impaired glucose tolerance, that is post-glucose tolerance, post-glucose load. So there can be IFG or IGT. There can even be a phase of honeymoon. Honeymoon period is something that we learn with type 1. But here you will find that there are young adults, young population coming to you saying that, yes, we were diagnosed sometime earlier, but then we took care of our lifestyle and what we know as remission or reversal of diabetes. So there can be people who can still be in their remission phase. But very soon, if left to themselves, if left uncared, they will present to your OPD very soon with type 2 diabetes. Then, of course, there can be women presenting with gestational diabetes. Ultimately, they are the vulnerable population most likely to develop type 2 diabetes. So let's begin with type 1 diabetes in young. So type 1 diabetes, how do you make a diagnosis? Most important, you must have the circulating autoantibodies. Now, these autoantibodies can be the islet cell antibodies or they can be the cytoplasmic antibodies. So we can have cytoplasmic circulating antibodies, we can have insulin antibodies, GAD65 happens to be the most common antibody. Then you can have insulin antibodies again, you can have the zinc 8 transporters. These are the most common antibodies, but besides and beyond these, there are many more antibodies that can be positive. Now, this population having antibodies or autoimmune predisposition when subjected to certain environmental factors, which can be in the form of toxic food or early exposure to milk, cow's milk specifically, or exposure to certain viruses. Specifically, we talk of the coronavirus nowadays. So any population with a genetic vulnerability when exposed to the environmental factors are likely to develop beta cell destruction. This population type 1, usually they do not have a family history. The concordance rate even in the identical twins is around 30 to 50%. So they are also not 100%. Family history is more strongly associated in type 2 diabetes. Now, the rate of beta cell failure is again quite variable. There can be sudden steep fall, that is steep developing diabetes, or sometimes it is postponed quite some time, and we find them only in the adult age, that is after 25 or after 30, and we label them as LADA or the latent autoimmune diabetes of the adult. Now, type 1 again is of two types. When there is strong antibody positive, that is autoimmune predisposition is clear, we label them as type 1A. So type 1A individuals will have a very steep journey. They will develop antibodies. If they have more than one antibody positive, they will have very low C-peptide, and very soon they will have a significant hyperglycemia. So low C-peptide, undetectable C-peptide with autoantibodies, and again, they will have many more coexisting autoimmune conditions. So such population will have either autoimmune thyroiditis or they will have celiac disease. They can even have Graves. They may even present with vitiligo or pernicious anemia or even Addison's disease. Now, besides this, they have HLA predisposition. So the HLA areas or the regions which are most commonly associated with autoimmunity type 1 diabetes is DQA and DQB loci of the HLA complex. If we fail to identify any of the antibodies, does not mean that this individual may not have type 1 at all. Even in the absence of autoantibodies, if the clinical picture supports the diagnosis of type 1, that is, they have low insulin levels, low C-peptide levels, low BMI, needing insulin, early onset, then still they have type 1 and we label them as idiopathic type 1 or type 1B. They are still prone to ketoacidosis. They may not have autoimmunity, but still they will have hyperglycemia with low C-peptide and predisposition to ketoacidosis. So we label this population as type 1B diabetes. Now coming to the most burning topic of T2DM in young, that is type 2 diabetes in young. So this was the very first case was identified way back in 1970. And the earliest child today that has been reported to have type 2 DM is a 7-year-old child. So it was first identified in 1970 and it is becoming the biggest burning problem of today, that is childhood obesity. It is mirrored by childhood obesity. It is characterized by insulin resistance. You know, there's a graph. So as the insulin resistance is increasing, you will find there is hyperinsulinemia. As the resistance is increasing, the body tries to compensate by increasing insulin. So there is hyperinsulinemia. So there will be markers of hyperinsulinemia or insulin resistance in the form of either acanthosis nigricans, there can be PCOS, but finally when the body fails to make this even and the insulin levels drop, there is occurrence of prediabetes or type 2 diabetes. So when the beta cells finally fail, it is hyperglycemia and that causes type 2 diabetes in young. Ketoacidosis is rare, I should say, in such children or such adults who actually have a pattern of type 2 diabetes. Now, the rising prevalence, why is it happening and what do we label it as? It's a new diagnosis. We are now calling them YOT2D, that is youth onset type 2 diabetes. So this YOT2D population is becoming very, very increasing in number, beginning from 117 in 1990 to 183 coming to by 2019. So we have a rapidly increasing number of this YOT2D. And this is not an Indian scenario. This is a global scenario, as you can see. You go across the world and you will find that all this population, wherever the projections are, they are failing us. And the YOT2D, all the population with type 2 DM in the age group of 20 to 29 is vastly increasing. So what are the risk factors? Why it is happening? Of course, the factors remain the same. Physical inactivity, a strong family history. Strong family history contributes not only by giving or sharing the genes, but also by sharing the table, by sharing the food, and sharing the lifestyle. Then we have the ethnic background, especially the Asians, the Indian ethnicity. We are very strongly predisposed to develop the YOT2D. Signs of insulin resistance such as acanthosis nigricans and PCOS will be present. It is accompanied by hypertension, hyperlipidemia, and to add to that, now we have MASLD. So the metabolic syndrome or syndrome X, as you call it, or insulin resistance syndrome, it is on the rise and it is taking an earlier age onset. Another group with a previous history of gestational diabetes, women is more likely to develop than males. So 2:1 age group, the women in the younger age group is more likely to develop type 2 diabetes. BMI above 27. If you are looking at the growth charts, BMI above the 85th centile for age and gender, weight for height more than 85th centile, or as we call commonly the waist height ratio of 0.5 or more than 0.5, again, a strong risk factor for the development of YOT2D. Or if you are more than 120% of your ideal body weight. And how do you calculate your ideal body weight? Height in centimeters minus 100. So if my height is 165, my weight should not be more than 65. Then of course the ethnicity. And when do we begin suspecting a YOT2D? It is around 10 years of age or puberty. If puberty happens earlier than 10 years, then again the child is at risk of T2D, or otherwise around puberty or anytime after the age of 10 years, we start suspecting a YOT2D. So when do we test? As per the guidelines, all the international bodies support after 10 years of age or at the onset of puberty, whichever is earlier. If the individual is overweight, as per the guidelines, that is more than 85th centile for the age and gender. If there is a family history of first or second degree relative, if you belong to any of the vulnerable races, that is Africans, Hispanics, Asian, South Pacific, and Native American descent. Or if you have signs of insulin resistance, that is acanthosis nigricans probably, and in girls PCOS, or in a woman history of GDM. So how do you diagnose? The diagnostic criteria still remain the same. You check a fasting blood sugar, and the fasting blood sugar, if more than 126 or higher on more than 2 occasions. If it is less than 126 and still you are clinically very strong of your diagnosis, the testing should anyways be repeated after every 2 years. How do you treat? If it is a case presenting with diabetic ketoacidosis, or it is presenting with non-ketotic hyperglycemia, hyperosmotic state, insulin remains the treatment of choice. Otherwise, if it is just a clinical suspicion that has led to the diagnosis of type 2 diabetes, medical nutrition therapy, weight loss and increased physical activity, that is LSM modification, lifestyle modification. At least give it a trial for 6 weeks, but we don't waste time with that much of it. After 6 weeks, if the patient or the population is not complying, we start with metformin. We can still start in the pre-diabetes stage also with metformin. Now we also have the approval of GLP-1 RAs for children more than 12 years. We also have molecules like SGLT2I. They can also be used in young adults, but not in type 1 without insulin because of the chances of euglycemic diabetic ketoacidosis. So because of the risk of the euglycemic DKA, we do not use SGLT2I very confidently without insulin in the young population where we are suspecting a type 1 maybe. But other than SGLT2I, you can definitely go for metformin with GLP-1 RA. And of course, insulin is still the first drug of choice in young population, less than 18 maybe, or even 25 if you want to talk. So other than type 1 and type 2, a very rare incidence of 1 to 3% is shared by MODY. MODY is maturity onset diabetes of the young. Yes, MODY with a Y. MODY with a Y. Remember that. So maturity onset diabetes of the young, it is a monogenic, autosomal dominant, heterogeneous form of diabetes. So it is a monogenic form, but we have more than 14 variants of MODY now. They are autosomal dominant. They are all related to a defect in insulin secretion and not insulin resistance. The share is only 1 to 3%. Presentation, most commonly we have read is 25 years, but yes, it can be around 25, not exactly that there's no London clock that is going to ring at 25. No, nothing will happen. It is around 25, anything between 10 and 30 years of age. And there is a strong 3-generation history. There are cases reported as early as 2 to 3 years, but they are all rare cases. We remember that it is around 25 years at presentation, and we have a strong 3 generations involved, right from the grandparents, parents, and if you miss a generation, you are missing the diagnosis. MODY is not the diagnosis. Most of them are not overweight. And the diagnosis should be entertained in children and adolescents with a strong family history with multiple generations involved. Now, MODY 1, 2, 3, 4, 5, we have 14 of them, and we have a various different genetic mutation involved. We are not discussing them individually, but one I will name is glucokinase, that is MODY 2. Now, they have a very, very different pathology, and you don't treat them. They don't need a treatment. The trigger is hyperglycemia itself is a trigger for insulin release. So whenever practically what they say is that the glucose sensor threshold is raised. So when the glucose sensor threshold is raised, whenever there is hyperglycemia, a little higher glucose is required for the insulin secretion. So they never need treatment. This is some of the pathophysiological factors here. You can see that these are the genetic mutations involved, any one mutation in one variant, one type. And this is the challenging rate limiting step here. So once there is a block here, this potassium channel is not closed. Because this potassium channel is not closed, calcium does not enter, and if the calcium does not enter, insulin is not released. So when to suspect MODY? If you are thinking of type 1, but the antibodies are negative, maybe it is MODY. If you are thinking type 1, but there is still a significant level of C-peptide, proinsulin, and insulin for a significant number of years. Don't confuse here, because all type 1 might have some C-peptide at presentation. But I'm talking here if the C-peptide persists after many years and you've been thinking type 1, probably you are dealing with MODY. If your clinical diagnosis was type 2, and the individual is normal weight with no signs of insulin resistance, maybe it is MODY. A diabetes with a family history and early onset for 2 to 3 generations, again, it can be MODY. If it is a diabetes which is paired with pancreatic insufficiency, probably it is MODY. If you have an individual or a family history of diabetes which is paired with developmental kidney defects or kidney cysts, then again you have one variant of MODY. Genetic testings, the only confirmatory method is go for a genetic analysis. You have a genetic testing for MODY. You can send a sample from blood or saliva. All mutations may not cause hyperglycemia, as we just understood that there are certain mutations where hyperglycemia is actually needed, a particular cutoff is needed. There are 50% probability of inheriting the genes and 50% probability of carrying the gene mutation. So the treatment is MODY 3 and 1, they can actually be treated with sulfonylureas. Glucokinase deficiency MODY does not require treatment at all. And other types require insulin most of the times. Now coming to another variant of a young presentation, and that is LADA, that is latent autoimmune diabetes of the adult. Now this variant or this variety, we had just touched earlier also when we were talking of type 1, when we were looking into the progression of type 1. So there are certain variants which progress very slowly. Antibodies develop, but those antibodies are either less in number or less in load. They may be just one single antibody, or maybe two progressing, or maybe the load of antibodies is less. The beta cells are dying very slowly or failing slowly. So they present around 25 years or 30 years of age. They are lean, thin individuals, no family history. So slow onset. But when you look for the antibodies are positive, especially the GAD65 antibodies are positive. And you will now label them as layman term, not a very colloquial term, I should say, is type 1.5, 1.5. In between, there was an era when we used to study even 1.25 or 1.75 variants of diabetes. But ultimately, the summary is that all these variants are the individuals who will require insulin, who will have antibodies present. They will lean or incline towards the diagnosis of type 1 and not type 2. Though mistakenly, we do treat them with OHS for quite some time, maybe 6 months, maybe 1 year. They give you a history that, yes, I was started by somebody on OHS and I took the OHS for quite some time. So the characteristic of LADA will be adult onset. Initially, they are all non-obese variants. They are controlled by nutrition and exercise. They gradually become insulinopenic, positive for autoantibodies, low C-peptides, and they do not have a family history of type 2 diabetes. If you want to compare them with T2DM, C-peptide is a very strong marker. They will have low levels, whereas type 2DM will have either normal or high. GAD antibodies will be positive, leaning towards type 1. Early age of onset as compared to T2DM, they are usually non-obese individuals, no family history. They are ketosis-prone individuals because a variant of type 1. They require insulin after the initial 6 months of age. 6 months of age, not by the chronological age, 6 months of diabetes diagnosis age. So history of 6 months of history of diabetes. So perform a GAD antibody. If it is positive, then you are dealing with a LADA. Now, how do you manage LADA? LADA will require insulin very soon. So if you diagnose it correctly, begin with insulin. If somebody has missed the diagnosis, as soon as you diagnose, start with insulin. So because of the destruction of beta cells, they become insulin dependent and they are not the classical type 2. They will require insulin very soon. Then another young presentation of diabetes, a variant of type 2 is diabetes in puberty or around puberty. Now this is again a very common presentation. You will find that around puberty, there is rise in sugars. So the hyperglycemia around puberty is very, very common. Even in type 1 diagnosed earlier than puberty, the blood glucose worsens around puberty. So the HbA1c worsens around puberty. A child diagnosed around say 6 years of age as type 1, you will find a child doing very good, but around puberty, you will find that the sugars are worsening. Similarly, in the non-diabetic children, you will find that around puberty, the sugars are high and they unmask diabetes during puberty. The reason being the androgens or the estrogen or the puberty or the sex hormones, of course, and besides the sex hormones, of course, there is a jump in the growth hormone. The growth hormone or the sex hormones, they are all causing hyperglycemia. And they also contribute to insulin resistance. There is increased insulin resistance. So puberty sets in insulin resistance because of the increased production of growth hormone as well as sex hormones. Insulin requirement, even in a stable child, goes up by 50% and HbA1c should be closely monitored. Now, certain other specific variants of diabetes, secondary diabetes, which are again commonly presenting in young. One of them is any defect of the pancreas. It can be pancreatitis because of chronic alcohol. It can be pancreatitis because of calculi. So chronic pancreatitis because of any reason. Then abdominal trauma causing damage to the pancreas. Infection of the pancreas, CA pancreas, pancreatectomy. So anything that will damage the pancreas will of course cause hyperglycemia. Then certain other endocrine causes like Cushing syndrome most commonly. Acromegaly is another. All these will cause hyperglycemia. Even thyroid dysfunctioning will disturb your blood glucose. Then, of course, drug-induced, like steroids specifically, or certain chemicals or cytokines that disrupt the insulin secretion or cause beta cell destruction. There are certain the oncogenic molecules or the molecules which are commonly used in oncology, especially CA breast. So that causes hyperglycemia significantly. Then infections causing damage to the pancreas or any infection-related hyperglycemia is very common. Then some uncommon specific form of immune-mediated diabetes. Some syndromic diabetes like the Down syndrome or the Prader-Willi syndrome, Friedreich's ataxia, all these are syndromic variants which are associated with hyperglycemia. Then another colloquial term which has not got its place in Harrison or which did not get its place in books, but used in the layman language is double diabetes. Double diabetes is not something that we can miss out because here we have type 1 children who are eventually overfed and they become obese, or you find obese children having antibody positivity. So they have features of type 2, but they have antibodies positive. So double diabetes, another group where we use very loosely the term type 1.5, which is characterized by hyperglycemia, obesity, and of course, antibodies also. So it may occur in children with type 2 having antibodies positive, or it may happen that type 1 children become overweight as they grow adults. And this was the term which was first introduced by Libman and Becker co-workers, and this double diabetes has come to stay. Then we have another syndromic variant, that is the Wolfram syndrome. Wolfram syndrome goes by the name of Did-Mod syndrome, that is diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. These children are having neurological developmental defects, so they are mentally retarded. They have some lower IQ. and they have a typical spectrum, a familial, of course, it is autosomal recessive in inheritance, but then we have this genetic defect that is WFS1 defect, and this population runs a complete whole family. You will see they have the syndrome. Then you have the Elstrom syndrome or the Bardet-Biedl syndrome. These are all syndromic babies who are actually obese. So obesity-associated syndromic adults will have hyperglycemia. Another important diagnosis which is associated is cystic fibrosis adults presenting with hyperglycemia. Now, they have a very short lifespan, of course, but there is thick mucus secretion which is affecting not only the respiratory bronchioles, but also the pancreatic duct. As a result, you will find that there is loss of insulin, there is loss of insulin, and these are the individuals who will have, they are fed, they are persistently overfed because they need nutrition, they need proteins, they need fats, essential fatty acids. So they are always overfed. And so their sugars are very difficult to manage. They're all high, they are on high calorie, high protein, high fat diet. They only need insulin. So cystic fibrosis diabetes is another young diabetes. Then one rare variant which is found only in the tropical areas is the fibrocalculus pancreatic diabetes. Another very interesting variant, very rare variant. These are the individuals who are ketosis resistant. Also, not only ketosis resistant, these are the individuals who do not develop micro or macrovascular complication at all. And this is a line taken from Harrison's. They do not develop any complication. They are fibrocalculus pancreatic diabetes. They have to come from a tropical area. Our own, very own Indian legend, Dr. V. Mohan, has given the diagnostic criteria for the FCPD, that is fibrocalculus pancreatic diabetes. They have beta cell failure, but at the same time, they also have alpha cell failure. So there is neither insulin very high, nor they have glucagon very high. So there is hyperglycemia, but not very high sugars. They also have carnitine deficiency. They also have fat deficiency. They have low adipose mass, so subacute fat is also very, very low. As a result, there is no microvascular complication, no macrovascular complication, but they are in need of treatment, that is insulin. So patient, as per our own legend, as we were talking, V. Mohan, sir has given us a diagnostic criteria, that is patient should be from a tropical country, diabetes should be present, chronic pancreatitis should be present with no underlying cause of chronic pancreatitis, that is alcohol or hepatobiliary disease. If we have no other cause of chronic pancreatitis, if it is only the tropical environment that is contributing to the calculus pancreatic diabetes, it is fibrocalculus pancreatic diabetes. Now this young diabetes, there are many variants, but if you just sum up everything, it will come down to that we are facing the challenge of rising UT2D, that is young onset type 2 diabetes, and that is what we are worried. And that requires a team approach. It is not me alone, it is not you alone. We doctors, we are the last people whom these population come and sees. It begins with parents. Right from childhood, we counsel the parents to stop overfeeding the children. Stop overfeeding the we start counseling with the grandparents, I should say. Stop overfeeding that ghee and the saturated fats. Then, of course, you need to counsel the school teachers, the environment in the school. It has to be more around playgrounds, health checkups, education around nutrition and lifestyle modification. Then, of course, the society has a role. We have to make the society environment safe, where we can send our children out for playing. We have to make them move out of these screens again and let them cycle, let them play, run around, or basketball, football, any of the physical activity, sports. So society and the government comes into play. Then, of course, the children and adolescents, they learn from us. So we as adults have to start exercising, look into our nutrition, our diet pattern. So we as doctors play a role. Then we need a nurse educator. Family, siblings have a role. Child psychologist has a very important role in the team. Pediatricians to look after the increasing weight, or monitor or plot the growth charts. Most importantly, the pediatricians have stopped plotting the growth charts. We need the dietitians, we need the family, especially the grandparents, the uncles and aunts, and India where love is equal to food. We celebrate with food, we mourn with food, we cry with food, we laugh with food. So we equate food with everything. So that has to be looked into. Then all other caregivers, they also come into part, and it's a teamwork. So why are we so worried? But we are worried because beta cells decline more rapidly in young onset type 2 diabetes as compared to the late onset diabetes. The complication risk is higher in young onset type 2 diabetes, not in type 1. Why? Because in young onset type 2 diabetes, there are two factors. One is they have a long lifespan with type 2 diabetes. So the complications have a lot of time to occur. Secondly, type 2 diabetes, you will say the lifespan is for type 1 also. Agreed. But type 2 diabetes has a predisposing time of hyperinsulinemia, which is not here. So this hyperinsulinemia causes atherogenic complications of the vascular endothelium. So the risk of complications in young onset type 2 DM is higher as compared to late onset because of the longer duration of the disease, that is long lifespan. Then the ethnicity and the intrauterine environment. Yes, the ephemeral organ placenta, the ephemeral organ that we have placenta, it has a big role to play. If it is a female fetus, you are affecting 3 generations. If it is a male fetus, you are affecting 2 generations. So the intrauterine environment has to be very, very healthy. So the prevalence of young onset type 2 diabetes is again very high in young adolescent girls because of higher incidence of PCOS. So we are more worried about the young onset T2DM. This is a data showing comparison of T1D and T2D. You will find the complication rate in T2D children is higher because of the preceding era of hyperinsulinemia. If you look at the data now, not only from our country, they have looked into this problem across the globe. The diagnosis is vastly changing. Now we don't have only type 1, we have type 2 19%. That is way back in 84. Now if you look at this data, now in India, diabetes in young, you will find 40% is type 2, 40% equal incidence with type 1, 15% of the fibrocalculus, some 2% of the Flatbush, and 2% Modi, 1% we have the rare variants of mitochondrial diabetes. So now when a young adult comes into your chamber and with hyperglycemia, the first thing you look for is a family history. If the family history is positive, 3 generations involved, yes, ketones absent, C-peptide present. What do you think? You think of Modi. If there is no family history present, ketones absent, obese, C-peptide present, you think of early onset type 2 diabetes. If an adult comes to you with family history negative and ketonuria positive, C-peptide absent, you think of type 1 diabetes. Then you look for antibodies. If the antibodies are present, it is type 1D-A. If the antibodies are negative, it is type 1D-B. Then you have FCPD if the individual is coming from a tropical area. It can be genetic at times if you look for the genetic defects, or rarely if it is Cushing's or acromegaly, it is endocrine diabetes. So this is how a whole spectrum of diabetes in young comes to you, and you have to lead to a diagnosis and treat accordingly. So this was the time, this is type 2, we began here. We started coming this way, the journey began this way. Now this is becoming the burden because type 2 is moving this way. Instead of moving this way, it is moving this way. And type 1 is moving this way. So now we have the LADA coming culminating here, and we have the type 2 culminating here. So type 1 is moving in this direction, type 2 is moving in this direction, and what we are having the challenges of YOTDM. So we have the young onset type of diabetes type you have to find out. So it is young onset diabetes, and which is all culminating here. So this is about diabetes in young. I think we are still having some 15 minutes in hand. If we have any discussion, we can take it further. Thank you so much for being with me this afternoon. And thank you, Dr. Puneet sir, for giving me this opportunity once again. Thank you, ICP. Thank you, API.
Dr. Meenal, I don't have any question to ask, but a comments to make. It was an amazing and excellent presentation.
Thank you so much,
Congratulations to
sir.
you. Congratulations to you, Dr. Puneet, and the entire ICP team. It was amazing. Maza aa
Thank
gaya.
you, sir. Thank you
In
so
a
much, sir. Honored.
simple way, maza aa gaya.
Honored,
ठीक है,
sir. Honored.
ठीक है.
Thank you.
Thank you. Thank you.
So we have some questions in the box, and one that is I can see is coming from it is Dr. Saitaja. Dr. Saitaja has asked, can we reverse it with diet and lifestyle? If it is a type 2 variant, Dr. Saitaja, yes, this is what we are talking. Rather than reversing, let's emphasize on preventing. Let's begin with primordial prevention and prevent the risk factors itself for type 2 diabetes. But still, if we can't begin with primordial, begin with primary prevention. And that has been one of the data that we have, the diabetes prevention studies. But even if we have already developed hyperglycemia, definitely, yes, we can go for remission, we can go for reversal, or you can say control diabetes with lifestyle modification is the one of the chosen words. You can do it and you should do it. We get a recording of the session. I think 3 Dots is our partner in this. So 3 Dots, we have a representative from 3 Dots. They can answer our question. Maybe we can have the recordings of the session, of course. Dr. Yasmin has a question. How safe is insulin pump for young adults, as dose has to be regulated by oneself in certain meters and they skip meals also? That is wonderful, Yasmin. Yes, insulin pumps are always the right answer for anybody and everybody. They are just the latest insulin pumps, the most hybrid variants where we are just mimicking the natural system of insulin secretion. Very correctly said that they have a basal rate, then they have the bolus rate, and you can always titrate your bolus. You can always titrate your basal rates also. And now these newer insulin pumps, they're also coupled with CGMS. So you can continuously monitor your blood glucose at the same time, and you can accordingly titrate your insulin and you can deliver your insulin. They do give you the flexibility that if you skip meals, of course, you have to skip your bolus and continue with your basal. So definitely, yes, if the affordability is permitting, do go for insulin pumps, and they are very good, very efficient in almost all the scenarios where the patient is on insulin. So do we have any more queries here? I can't see any more queries in the chat box. So Dr. Yasmin has another question. At what HbA1c level SGLT2i should be added to metformin? Yasmin, now that is a question which has to be individualized. And instead of putting it as why SGLT2i, I would say any second molecule whatever you want to add. So what is your target HbA1c? That depends. If your target HbA1c for that particular individual, depending upon his comorbidities, his age, what is your HbA1c target? If it is a young population, young gentleman or a young woman, I would say my target would be less than 6.5. Then yes, even if the HbA1c is more than 6.5, I would suggest let us go for a double molecule, 2 molecules. If it is a gentleman of around 80, 85, and if well maintained on HbA1c, well maintained on metformin, and even if the HbA1c is 7.5, I would not suggest adding another second molecule. So HbA1c target first needs to be individualized. If that is set, then you can think of switching on from monomolecule, like single molecule therapy, or a double molecule or a triple molecule. So depending upon your patient, you can individualize your treatment. How we get that is, do we need to differentiate insulin resistant and insulinopenic patients before starting insulin therapy in type 2 diabetes? Okay, so Dr. Pathania, what I understand from this question is, do we need to differentiate? See, insulin resistance is always a part of type 2 diabetes pathophysiology. So as long as the patient is managing insulin resistance by hyperinsulinemia, such patients will clinically be having normoglycemia. They will only have markers of insulin resistance like acanthosis will be there, obesity will be there, or there can be fatigue, muscle fatigue can be there, but they will not have exactly overt hyperglycemia. Overt hyperglycemia is present, then you don't need to establish insulinopenia to start insulin. Once there is overt hyperglycemia, that is a diagnosed case of type 2 diabetes, you can treat anyways. You can choose your treatment if you want to treat with insulin, if the patient is willing and you want to start with one basal insulin or a basal bolus insulin or even a premix insulin for that matter. You can begin with insulin therapy if you want to begin with insulin therapy. If you want to begin with OHA and then go to insulin. See, treatment individualization is a very big topic. You can choose your own individualization, but you don't need to establish insulinopenic condition to treat type 2 diabetes. So what HbA1c level should be maintained 75 years old with or without comorbidity? Again, right, very interesting. So for a gentleman of 75 years without comorbidity, how is he clinically? If clinically he is maintaining himself fit, educated class with a backup in case of any emergency, I would say you can keep HbA1c up to 7. If there is comorbidity like renal failure is there, CKD, CLD, or any other complication like CAD, a patient of bypass or a patient of CAD, a less educated class maybe, or a rural background, not having a social backup in case of any emergency, I would say we can have a relaxed target of even 7.5 or even relaxed of 7.5. 8 would be a very liberal, but 7.5, of course, for a 75 years old gentleman with a comorbidity is quite acceptable. Then comes what is the importance and use of HOMA index and fasting insulin level. So Dr. Nirali has asked a question of HOMA index and fasting insulin levels. Nirali, these are Dr. Nirali, these are more of academic value investigations. If you are writing a paper, if you want to establish a research protocol, then of course HOMA index and fasting insulin levels are measured, but very rarely clinically of any help. Most of the gynecologists do ask for fasting insulin levels when they want to establish a diagnosis of PCOS. But otherwise, in clinical scenarios for the treatment of the patient, neither fasting insulin level helps us nor HOMA index helps us. They are more for research paper writing and more for academic interests. They are not going to change your treatment. If HOMA index is telling you there is a significant insulin resistance, clinically also you know there is insulin resistance, you will anyways give metformin. So how will it help clinical in your practice? Not very sure. Similarly, fasting insulin, if there is hyperinsulinemia, first of all, we rarely go for insulin levels because the labs are not very well equipped, because to check the serum insulin, you need to transfer the sample very quickly to the lab, and they have to be transported in a very specific environment or specific conditions. Otherwise, what we need to know is the C-peptide, because the C-peptide level parallels with the insulin levels. C-peptide has a longer T-half, so it remains in the serum for pretty long. So C-peptide actually mirrors your insulin level. Otherwise, I don't know why do we do a fasting insulin, but still if you are doing it, it will only tell you that there is a high insulin level, that is hyperinsulinemia, which is again a marker of insulin resistance. If it is low, then again, you will just know that there is insulinopenic condition. And of course, if there is hyperglycemia with insulinopenia, you need to treat with insulin. Okay, so Dr. Yasmin has another question. She's asking, if metformin is not suited, what other medicines can be used to combat insulin resistance? Very good, very nice. So we all know the answer, of course. If patient is not tolerating metformin because of GI intolerance, I will not say we should go for GLP-1RA, but otherwise pioglitazone or thiazolidinediones are the second molecule of choice to target insulin resistance. If the patient has no water retention history, no CHF history, not very obese, and you want to target a lean individual with insulin resistance, you can choose pioglitazone, that is thiazolidine-diones. And if metformin is not tolerating, then of course, thiazolidine-diones are the another group of molecules that are known to have insulin sensitivity improvement or insulin resistance decrease, the molecules that are known to decrease insulin resistance. Otherwise, if you are targeting MASLD or other molecules, we have the newer molecules like GLP-1 RAs we have now. You can use GLP-1 RAs. Even tirzepatide has been launched 2 days back in India. So tirzepatide is another molecule to target your obesity or weight issues and insulin resistance issues now. Anything else that I can help you with this afternoon? Yasmin has one more chat. Oh, thank you. Thank you, Yasmin. Welcome. You're always welcome, ma'am. Anytime. Nirali, ma'am, thank you. Dr. Puneet, sir, if you are here in the meeting any longer, can we close the meeting with your kind permission? If we have no more queries,
Madam, you spoke a very nice line. We Indian celebrate everything with food. We are the food lover. We celebrate party with food. We mourn with food. Uthale mein khana or lovely line. I think we should all remember this line forever. Wonderful line. I salute you for giving this beautiful line.
thank you,
Aloo
sir.
puri, and that also aloo puri and halwa every time. Bandare mein, uthale mein. Good. ठीक है. Thank you very much for the wonderful session. Thank you very much.
I think Dr. Puneet is busy somewhere. So if by the permission of 3 dots, can we close the session?
Yes, ma'am.
Once again, thank you everyone for joining me, and thank you, Dr. Mukesh Bhatia, sir, for your wonderful inputs. The entire team, Dr. Yasmin has actively participated, Dr. Nirali Dave, Dr. Anuj Sharma, and all my colleagues who've made this session very interactive. Thank you. Thank you, 3 dots. Thank you, Puneet, sir.
Thank you, ma'am.
you,
Thank you, ma'am.
Thank you, ICP. Thank you so much.